Hi there, this is your instructor, Christina Howard, back at it again with video recording. So let's get started. Excuse me. My voice is a little bit weird today, so if I don't sound like my normal self, that's why. But I wanted to make a video to update you and try and get caught up on recording. So here we go. Alrighty, so we started this in Zoom, but I wanted you to have access to the pre-recorded version of it. And so once I'm able to get to the next gosh darn slide, we'll start. Okay, so it's a waste of your time to read this to you. I'm just going to kind of go over the key points of this, and then we'll sort of get going on the rest of it. So we're going to talk about the circulatory system, and the circulatory system includes the heart, which is basically a muscular pump, but also includes tubes that your blood travels in, those are your blood vessels, and lymphatic vessels that carry away what leaks out of the tubes. So the lymphatic system and the circulatory system are technically separate, but they are linked. So we're going to talk about both of them here. We'll talk about the histology of the heart and the different layers and what their jobs are. And we'll also discuss some special properties of the heart, including the fact that it can generate action potentials without any input from the nervous system, which is pretty neat. After we talk about the heart, we'll talk about the blood tubes and what happens when things go wrong with them. So you'll have the opportunity to see, for example, what atherosclerosis looks like from a histological perspective, which is pretty awesome. All right, so that's a basic overview. Let's get to it. So on the left here, we have an actual dissected heart. It's triple injected, meaning that it's been preserved and injected with latex to show you various structures and also its vascularity. So you can see, well, let me point at it for you. So this is a cardiac vein, and then all of this like sort of blackish blue area, that's venous drainage of the heart, and then the red area are places with lots and lots of arteries. So the muscle of the heart itself works hard and it works constantly, so it needs lots of oxygen and nutrients, which is why your heart itself receives the blood that it pumps, and I'll explain how that works along the way. Over on the right-hand side, we have a little bit more simplified version. The word unidirectional here is very important. So the valves that we're going to discuss control the path of blood through the heart such that blood should never go backwards. So you can think of the heart as being a house with 4 rooms. And as you enter the house, once you enter a room, you can't leave it. You can only go to the next room, or you can only leave it by going to the next room. You can't go out of the door you came in. That's how a healthy heart should work. When blood moves backward within the heart, that's often called valvular regurgitation. And what that means is your valves aren't functioning properly, and that's a problem. This is a reason that people have valve replacements, for example. So the heart needs to be this way because it has to separate oxygen-rich blood from oxygen-poor blood. And in order to do that, you have 2 different circuits. So you have the pulmonary circulation, which is the circuit that goes between the right side of the heart and the lungs. So basically, oxygen-poor blood comes back from the systemic circulation via the 2 venae cavae, so the superior and inferior. And the heart says, okay, let's get this blood and let's get it over to the lungs to pick up some oxygen. So that's what the right heart does. The left heart takes that oxygenated blood from the lungs via the pulmonary veins, and it sends that blood via the left ventricle out into the system. The left ventricle's myocardium, the muscle part, is a lot thicker because there's a lot more resistance in the systemic circulation, which means that the pressures that need to be generated to perfuse those tissues have to be higher. So we'll build up those concepts along the way as well. Alrighty, so here we have a little bit of a different view. So this is same two circuits, so your pulmonary and systemic circuit, but instead of being simplified into boxes, this shows you the lungs and also the circulation of the head up here and then the rest of you, but we've boiled down those circuits into just a capillary bed, just for simplicity's sake. Okay, so one thing that I want to stress is that if you look at the pulmonary circulation over here, let's look at the picture. We've got pulmonary veins, pulmonary arteries, and notice that the veins are red and the arteries are blue. This is probably not the style of illustration that you're used to seeing. You're probably used to seeing arteries being red and veins being blue. And that's true in the systemic circulation, absolutely. But artery and vein is not a word that is used to describe the oxygenation state of blood in a vessel, but rather the direction in which that blood is moving. So an artery is really just any vessel that's carrying blood away from the heart, and a vein is really any vessel that's carrying blood toward the heart. So because your pulmonary veins are carrying blood toward the heart back from the lungs, it's a vein because blood's moving towards the heart, but it's red because that blood is carrying oxygen. And the arteries, by contrast, are moving blood from the right ventricle out to the lungs to go pick up oxygen, and they're called arteries because they're carrying blood away. So if you look closely at this slide, and I think I mentioned this in Zoom, but I want to say it again because it's a little bit misleading. This is an error in the PowerPoint that I did not catch before I started. It's one of those things where when you look at something so many times, you can't see mistakes as well. So pulmonary circulation includes pulmonary veins, pulmonary arteries, and the right side of the heart. If you look at the circuit labels over here, pulmonary circuit says lungs, veins, right? But then we get into the left heart, which should be up here. So just for now, until I fix them, ignore these because they're not quite accurate. They're a mixture between the two. So in classical anatomy, we divide left and right heart. The right heart is for pulmonary circulation, and the left heart is for systemic. So I just want to acknowledge that error so that you're not confused. That's not the classical definition over here on the left. So that's what I have to say about that. Okay, so I mentioned that one of the cool properties of the heart is that it is able to generate action potentials without input from the central nervous system. So this property is called autorhythmicity. So autorhythmic heart. And this is just a way of saying that there are special cells in the heart that basically depolarize spontaneously. And I'll show you how they do that in a second. It's something I didn't have a chance to do in Zoom, so I'm glad I'm doing this video. But there's this series of specialized muscle cell populations that start and impose order on the events of the heart. So your heart is a muscular bag. It's supposed to squeeze blood through the heart in a particular order, right? So imagine you are squeezing a balloon. So if you just take a water balloon and squeeze it, the area in your fist is going to have water move away from it, and then you're also going to end up with water in the balloon above your fist and below your clenched fist. That is not an effective way to eject blood from a heart. So what has to happen is your heart has to beat such that the atria up here first move blood down, and then they have to stop contracting, and then the ventricles, the bottom two chambers, have to move blood up after the atria. So there's two steps. First contract atria, then contract ventricles. And the way the nodes are arranged helps that to occur. So I'll show you that. So let's look at the heart a little bit before I talk about heart rhythm cessation. So we have the two top chambers, the atria, the left one and the right one. So the right atrium is home to a specialized group of cells called the sinoatrial node. I want to stress that these aren't neurons. They're cardiac muscle cells. They're just specialized. So they have something called a pacemaker potential, which I'll explain in a minute. So this fires first, and that excitation is going to spread across the interatrial septum into the left atrium. And this is going to depolarize the myocardium excuse me, of the atrium so that muscle can contract. So remember from muscular physiology when we talked about skeletal muscle, you have to depolarize the sarcolemma in order to let calcium out of the sarcoplasmic reticulum and trigger a muscle contraction. Myocardium is the same. It's striated muscle, so it has sarcomeres, and so it needs to experience depolarization as well. So an important thing to remember about this is that contraction follows depolarization. Not by very long, it's the order of milliseconds, but they are two separate things. So it's important to understand that contraction does not equal depolarization. That's not true. One follows the other. So in the Zoom session, we stopped after this atrial step, and I asked you a question, and that question was, if we know that all these cells are connected by gap junctions, and they are, what is to stop the excitation in the atria from traveling down and prematurely exciting the ventricles? And the answer that I shared with you is that the fibrous skeleton of the heart, which is made of collagen, is a good insulator, so it keeps the electrical signal from spreading where it shouldn't prematurely. So the job of the AV node and the AV bundle, which is this little guy right here that I'm coloring over, is to transmit excitation from the atria down to the ventricles in an ordered and timed way. And that's where we got into our discussion about tissue engineering and the ghost heart and all that good stuff. Okay, so I mentioned that I would show you how these cells work, and I will. So let me switch over to whiteboard really quick, and we'll do that. So for neurons, an action potential, if you measure voltage over time, looks like this. Let me draw my axes, and I'll label this too. So this is neurons, and let's put normal in quotes. Neurons and quote-unquote normal muscle cells. So there's some threshold. Boop, 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 boop. I don't know why I'm making sounds for my dotted line, but here we are. This is what I found myself doing. So I'm not going to put any millivoltages on the y-axis. You should just know that there's a change. I'm only focusing here on the waveform and on what channels are active. So unless a neuron or a muscle cell is excited by something, it's just going to kind of trundle along at resting potential. If it's binding neurotransmitters, which are opening ion channels or something like that, then we're going to get a drift towards threshold. If threshold is met, you get a rapid depolarization, repolarization, and hyperpolarization, followed by a return to resting condition. So that's a quote-unquote normal action potential. And these are only generated in response to stimuli. So you need to do something to the cell to make it experience that waveform. It doesn't just happen by itself, usually. So here is a difference, and this difference is called the pacemaker potential. Oh, oops. Okay, so line again. I'm gonna make this a little bigger. Alrighty. So with the pacemaker potential, and remember this is the type of potential experienced by the nodal cells of the heart. So not the regular cardiomyocytes, not most of the heart muscle cells, but those excuse me, those fancy ones that are the SA node, the AV node, the AV bundle, etc. So they have membranes that are leakier than normal. They still have a resting, or excuse me, a threshold. So let's draw that threshold. But instead of having a resting potential, because their membranes are leaky, there's more leak channels in them, they are always drifting towards threshold. And then they depolarize, repolarize, and then they just drift right back up. So there is no resting because of that ion leak. So I'm going to draw an arrow to the part of the curve that is leak channels. And then the rest of the action potential waveform is generated by familiar channels that you already know about. So this is voltage-gated sodium channels, and this is voltage-gated potassium channels, just like over here. So there are some similarities, but the major difference is the spontaneity. So no stimulus required. The cells just spontaneously depolarize because they're leakier and they drift towards threshold a lot. So we call this the pacemaker potential. So folks who have pacemakers installed in them that are a machine that helps set the pace of their heart, basically that machine is replacing the pacemaker potential because the pacemaker potential has been damaged or is gone for some reason. So that's the idea there. Oops, no, I don't want that. I want this. Well, it's wanting me to take a screenshot of something so I can make it go away, so I'm going to do that. There we go. Alrighty. So I just drew you the waveform of what's happening in these particular nodes. So after the SA node fires, then the AV node delays the signal for about 100 milliseconds or so. And then that signal travels down through the AV bundle into the bundle branches, which is just the two branches of the bundle. And then at the bottom of the heart, which is actually called the apex, I know it's not at the top, but it's the pointiest part, those populations of cells in the Purkinje fibers turn around and branch out to provide excitation stimulus to the rest of the ventricular myocardium. So that's the deal there. And another thing this helps to do, and again, this is something I mentioned in Zoom, but I can't talk about it for too long here, is that two things are important here. One, remembering that excitation is followed by contraction. That means that the ventricles contract from the bottom up, which is a really efficient way to eject blood from the ventricles. And then we talked about that myocardial vortex as well, which is just the fact that the direction of the muscle fibers, the way they're arranged, if you were to look at, let's draw a little eye here. If you looked at the heart down the apex, what you would see would be something that looks like this as far as the fiber arrangement goes. So when it contracts, it twists or wrings the blood out, like wringing water out of a washcloth. So that helps with the efficiency of blood ejection as well. Okay, so I just spent a lot of time talking about the myocardium, but there are other layers as well, and they're very important also. So this inset here is showing you, a little window view of what layers there are. So we talked about the myocardium, and this is, of course, striated cardiac muscle. So this is going to be varying in thickness according to workload. So in general, the ventricles have a thicker wall than the atria, And then between the two ventricles, the right ventricle has a thinner wall than the left because the left has more systemic resistance to overcome. On the outer surface, so just right here, I'm going to get rid of this stuff. There we go. We've got the visceral layer of the serous pericardium. So a serous membrane is a thin membrane. It's typically a single layer of squamous epithelial cells atop some loose connective tissue of some kind. In this case, a mixture of loose connective tissue like areolar and fat. Serous membranes secrete serous fluids, which are thin, watery, lubricating fluids, and that's true here as well. So the heart is in constant motion, and you want to avoid friction if there's constant motion. So having a fluid that lubricates is really important. Okay, so the myocardium, the endocardium is next. And this is going to cover the inside of the heart. So this is continuous with the inner lining of blood vessels. And it is a pretty simple layer. It's just a little bit of an epithelium. Pardon, my dog is next to me while I'm recording this, and he's having a dream, so he's making sounds. So if you heard some yipping, that was what was going on. Blinko's dreaming about something. Anywho, so endocardium-wise, it's a thin epithelial lining covering the surfaces of the inner heart. And this is the thing that I mentioned in the Zoom lecture about pericarditis is an inflammation of the pericardium. That's much more common than endocarditis. It's pretty difficult to get endocarditis, but it does happen. It's fairly frequent in intravenous drug users who use dirty needles because the needle gives bacteria access to the blood, and then the blood carries that bacteria into the heart. So if you're somebody who's going to be working in an emergency medical context, that's something you might encounter. So outside the heart wall, there's the pericardial cavity, which is right here. And remember I said that this is supposed to be a potential space, meaning that it's artificially wide here, so you can see the difference between the layers, but really the visceral layer and the parietal layer of the serous pericardium are touching almost, and they're separated by a thin film of fluid. If you get fluid that's not supposed to be in there, that is called cardiac tamponade. Because the fibrous pericardium is not stretchy, in general, dense irregular connective tissue isn't stretchy, and that is what that's made of. Because it's not stretchy, if there's any stuff that builds up in the pericardial cavity, it means that the heart can't expand as well as it ordinarily would be able to, which means that it can't fill, and the heart can only pump what it fills with, so it impairs cardiac efficiency pretty fast. So pericardial effusion, which is the movement of interstitial fluid into that space, can happen if you experience an increase in capillary permeability, or in some cases, blood ends up in there, or pericarditis, because as we know, during inflammation, tissue fluid is leaking out of blood vessels due to heparin and histamine action, but that can be dangerous as well. So be nice to the linings of your heart. They matter a lot. Okay, so we looked at the conducting system a little bit, and I think this is about where we ended. So what we're looking at here is the back of the left atrium and ventricle. So things that you can see in the zoomed out view right away are that the ventricle is a lot thicker than the atrium. So again, the atrium only has to pump enough to get blood down to the ventricle below, and most ventricular filling is passive anyway, so they don't need to be as muscular as the ventricles, which have to pump blood upward, and not only upward, but since this is the left ventricle, against the peripheral resistance of all of your arteries, which is considerable. So that's what you're seeing there. The star of this show is really this rectangle inset, and that is interesting because, as we pointed out in lecture during our Zoom session, basically I ask you guys to make observations about the difference between this chunk of myocardium and this one, and you all had great input. So you noticed it stains lighter, you noticed that there weren't as many intercalated discs, and it was less nucleated. So properties of these cells, even though they're technically cardiomyocytes, make them different from the regular cardiomyocytes that are here. So cardiac muscle fibers over here in CMF, these are special ones, and those are the Purkinje fibers. So this is only a difference that's viewable histologically, and as you can see, it's fairly subtle. So you wouldn't be able to, for example, pick up a dissected heart and look at it and find those. You'd have to stain for it. Okay, so here's another view, and in this case we can see that there's a additional layer of staining has been added. So this is probably a Mallory-Azan stain, it looks like, which combines H&E typically with additional dyes like the blue, which colors collagen. So we've got the endocardium, and this is an aventricle wall, as you can see. So the endocardium is here. So we've got this endothelium and connective tissue. And then we have intercalated discs, which are being pointed at. There, and there. So here we have, again, specialized conducting cells. Down here is regular myocardium. So you can still see striations in these, but they look very different from these guys down here. There's Purkinje fibers, which again are the specialized cells, and these stain differently because they have a lot of glycogen in them, and glycogen doesn't tend to pick up staining as well. So because of that, they have a different appearance. There's also nerves that belong to the autonomic nervous system. So these are going to be endings of the cardiac nerve, for example. So I mentioned that the heart can beat without input from the central nervous system. That's true, but in a normal, healthy heart, the conducting system receives input from the autonomic nervous system, so the sympathetic and parasympathetic, that modulates your heart rate. So increases your heart rate when it needs to increase and decreases your heart rate when it needs to decrease. So you can see that here in N as well. Or excuse me, NF rather. N is nuclei. Okay, so I mentioned a couple times that the left ventricle is considerably thicker than the right, and that's true. So you can see that really clearly, right? So if we look at the thickness of this guy, the ventricular myocardium on the left side is quite a bit thicker. And that's because it has to deliver blood to a system with a lot of resistance. So anytime you have a series of tubes, and I'm going to make these be red because we're talking about the systemic circuit. So here's the heart, here's the aorta, and then the aorta almost immediately begins branching, and those branches branch and branch and branch and branch and branch. And then also as they're branching, the diameter of the tubes gets smaller and smaller and branchier and branchier as you move further and further into the arterial system away from the heart. So a decrease in vessel diameter is accompanied by an increase in amount, I can't spell amount today, haha, of tubes. And all of that equals lots of resistance. which is why this myocardium has to be so thick. So it needs to be able to generate enough force to overcome that resistance to make sure that blood gets to where it needs to go. All the ventricle on the right side has to do is get blood to lungs. And the lungs are right next door to the heart, so that's a relatively easy task, right? So the idea there is that the amount of muscular work corresponds to the wall thickness, and that's going to differ from left to right depending on the amount of resistance experienced. Okay, so I showed you a picture of the fibrous skeleton. That was that decellularized heart I showed you guys during Zoom. So I won't revisit that, but if you want to look at it again, the search term is decellularized heart. You can find that. I've also seen circulating on Facebook and Instagram of that same picture that I showed you guys, but it says, this is what a heart looks like completely drained of blood. Nope, that's not true. Well, I mean, yes, it has no blood in it. It also doesn't have any muscle fibers in it. It's not white because there's no blood in it. That kind of stuff drives me crazy. Okay, so the fibrous skeleton is cool because it does two things. One of them was provide electrical insulation between the top part of the heart and the bottom, so the atria and the ventricles. And the other thing is just give it structural stability. So the valves are continuous with the fibrous network, and the fibrous skeleton helps to hold those valves open. So the stiffness of it creates these rings that stay open, and then the little flaps can open and shut with changes in volume and pressure. So heart valve defects can be produced by developmental defects. So you can just be born with a heart valve, or maybe like one of the cusps isn't fully formed, so the valve stays open a little bit. That's called stenosis. But more commonly, hypertension or infections or scarring will take a valve that is healthy and move it towards a valve that is pathological. So when you start to get issues with valve closure, blood flows backwards within the heart, and that produces a sound. You can hear the blood going the wrong way, and it reduces the pumping efficiency of the heart. So when this happens and when it gets to a particularly bad state, that will often be addressed by replacing the valve with either an artificial valve made of biologically inert materials like titanium and nylon, or in some cases a large animal donor valve from which the endothelium has been scraped off because those cells are immunoreactive, but the collagen is not. So this poses an issue for some folks. I think I mentioned this in lecture as well, because in some religious practices, touching certain animals is considered to be unclean and is a spiritual taboo. So a lot of cultures and religions believe this about pigs, for example. So, if your religion prohibits you from touching pigs, then you can't, for example, receive a porcine valve replacement. So that's just one of the weird intersections of bioethics and medicine and treatment. So one complication from having a valve replacement is that the new valve does not have the endothelial covering that the old valve did. It doesn't have stem cells to regenerate it either. Excuse me. So that means that blood cells tend to stick to it a little bit more, and that creates the possibility of forming a thrombus or clot. So if you have a valve replacement, you also need to pair that with being on anticoagulants to prevent blood from sticking to the valve. There we go. Okay. So I mentioned the endocardium needing to be scraped off of the valves for a valve replacement if you're getting a animal valve or a cadaveric valve. So ordinarily the valves and other endocardium, like the endocardium, is continuous over the valve, so it covers the valve itself. So the cusps, or the little flappy parts that close, that's what a cusp means. are normally avascular, so they don't have any blood vessels in them, but they are thin enough that they allow diffusion from the blood in the heart chambers to nourish the cells that make up the valves, so the fibrous connective tissue cells, etc. Valvular heart disease can include inflammation of the heart valves, and interestingly, that causes the valve to begin to secrete angiogenic factors, which are basically signaling factors that recruit new blood vessels to be made in that area. So your valves are supposed to be avascular because that is what allows them to work properly. But the vascularization can lead to improper deposition of collagen and elastic fibers, which causes the valve to become thicker than it normally is and make it inflexible, which is bad because an inflexible valve means that it can't fully close oftentimes. So again, you get valvular stenosis, which is the valve staying open, and then regurgitation of blood back through the valve. Okay, so I drew this out a little bit, but I want to sort of reiterate. Generally speaking, your arteries with distance from the heart go from being large, like the aorta, to very, very small. And the opposite is true of veins. So veins go from, or excuse me, the same is true of veins, but the blood is traveling in different directions. So veins near the heart are quite large, like the vena cava, and veins far away from the heart are quite small, right? So for arteries, this is just a nice summary table that tells you what layers there are and what they're made out of. So if you look at the top of the chart here, the tunica intima is the layer that faces the lumen, and the tunica adventitia is the outermost layer with the tunica media in between. So I'm not going to read this chart to you, but it's worth memorizing because it shows you how characteristics of arteries change between very large ones and very small ones. So arteries are not all created equal. They are specialized based on their size and also based on their purpose. One important thing to note here is the microcirculatory bed and the fact that here we have capillaries. So blood can go all the way through this capillary network. Why isn't my pen working? There it goes. Blood can go all the way through this capillary network and leach oxygen out into the tissue and take CO2 in. And going through the entire capillary network provides a lot of surface area for that blood to interact with. But there's another option, and that is the arteriovenosus anastomosis. That's what AV stands for, arteriovenosus. I'll write that word down for you. There we go. So this just means a direct path from the artery side to the vein side. So they can skip the capillary bed and just go from one side to the other. And this is achieved by smooth muscle cells that wrap around the arterioles. So if the smooth muscle here, for example, was closed, then the blood would just go through the arteriovenosus anastomosis instead of going through the entire capillary bed. So it's a way to control tissue perfusion, which is how much or how little blood is being provided to a particular tissue. Being able to adjust tissue perfusion is very, very important. It helps you regulate where blood is in your body and allocate more blood to tissues that are demanding more blood. Okay, so here we have the same chart, but for veins. So make sure you look. One thing you'll notice if you look at the constituents of the tunica, intima, media, and adventitia is a lack of elastic fibers in most cases, and differences in what's there, especially as it relates to how many layers of smooth muscle there are, Vein walls in general are much thinner, but veins have this cool feature, and that is valves. So valves prevent blood from pooling in your lower extremities. Basically, they're there to keep blood moving back towards the heart, ideally, and not away. The one exception is that you do have a valve in your jugular vein, and that is a valve that faces the other way, and it prevents blood from rushing into your head if you go upside down. So you have jugular vein valves that prevent you from dying by going upside down. Isn't that interesting? Okay, so here is a scanning electron micrograph. I almost asked you guys, and then I realized I wasn't really talking to you. I'm talking to a recording. Haha. I'm just so used to my lecturing pattern now. I mentioned that these are designed to be smooth and not sticky. So you don't want your blood vessels to get, or blood cells to get snagged on the circulatory endothelial cells, which is why they look the way they do. So the spindle shape, so they're long and skinny, have pointy ends, and they run parallel to the vessel. So they run in the same direction as the direction of the vessel, which reduces friction as well. So in the adult human body, a circulatory system, on average, and this varies a little bit because you can grow and shrink blood vessels depending on body size and amount of fat you have, but it's about 60,000 miles of different sized vessels lined with vascular endothelium. Earlier I mentioned I saw something on Instagram that annoyed me, so here's something on Instagram that I think is very funny. It's like one of those, did you know fact things? And it was like, did you know that if you took all the blood vessels out of your body and you line them up end to end, and so, you're set up to expect some sort of impressive length thing like the one I just showed you, so 60,000 miles. But instead, this one says, did you know if you took all the blood vessels out of your body and laid them end to end that you would be dead? And that cracked me up. Because duh, but the expectation is something different, so I thought that was funny. Okay, so I did promise you I would show you the histological features of atherosclerosis, and this picture actually shows that. So the vascular endothelium is a really important layer. It makes sure that the blood is flowing in the appropriate direction, and it makes sure that the blood is continually moving and that blood cells aren't sticking to the edge and forming clots. So that's healthy endothelium. Here's the deal. There are surface adhesion molecules, so those are here, but they have very specific purposes. So low density lipoproteins stick to them, insulin sticks to them, and histamine receptors stick to them. Endothelial activation is cells produce a new surface, so they change their surface constituents in a way that favors clotting. So part of the clotting process, which we'll talk more about when we talk about blood, it involves a change to the lumen-facing surface of the endothelial cell. So they go from being slippery to being sticky, and that facilitates a buildup of platelets. So tissue injury causes those endothelial cells to become sticky, and then platelets stick to the sticky part, and that initiates clotting. Emboli. So there are different kinds of emboli. An embolus is basically just a science word for a traveling disruption to blood. So you can have an air embolus, you can have a thromboembolus, which is a traveling clot. So in this case, we're talking about a thromboembolus. If the clot forms and is not disposed of properly, it can detach and obstruct blood vessels. So if the clot ends up in the myocardium, it can result in an infarct, which means an area of the myocardium that's not receiving adequate circulation. And that can, or if it ends up in the brain, it can cause a stroke, or in the pulmonary circulation, it can block blood from getting to the lungs to pick up oxygen. That's bad. So if someone is experiencing one of these, they're treated with intravenous tissue plasminogen factor. This is a factor that your cells naturally make to safely get rid of clots that form in you, but you can also stimulate its production in animals and harvest it and use it as a drug. So this breaks down fibrin and dissolves a clot, and which quickly sort of eliminates the danger of the embolus. Over here in this picture right here, we have a low density lipoprotein forming. Basically, monocytes are baby macrophages. Remember, we talked about those in our resident versus traveling cell populations of tissues. So the yellow balls here represent low density lipoproteins, which are proteins that are carrying lots of triglycerides, and they're called low density because the ratio of fatty acids and triglycerides to protein is high. So there's a lot of fat in these things. Monocytes perform diapedesis, so they pass through the endothelial cells, but they don't go all the way through. They end up under here, and they will eat up low-density lipoproteins and become what are called foam cells because their cytoplasm looks foamy. And so this is the beginning of what is called a complicated plaque. You also get platelet-derived growth factor, which is what PDGF stands for, and that's going to cause growth of cells around the foam cells to sort of wall them off. So this is what a complicated plaque looks like. It's not just fat on the inside of your arteries, as many people think. It's the result of chronically high levels of LDL and an immune response, essentially, to that LDL. Okay, so let's talk about the arteries that are near the heart. So we call these elastic or large arteries, and these help blood continue to flow by basically expanding when they fill with blood, and then the elastic fibers in them, which you can see very clearly right here, those elastically expand and then they snap back because of course they're elastic, and that pushes the blood further along. So they aid in blood flow, propelling blood into the circuit. Hardening of these creates increased peripheral resistance, so makes the heart work harder and makes the vasculature less flexible, which causes ultimately heart problems and circulatory failure. So it's very bad. So atherosclerosis, I mentioned earlier. Athero means gruel or porridge, and this refers to the foamy mixture that hardens, so those foam cells and the connective tissue that forms around them. And then scleros is hardening, so hardened porridge arteries is what this really means. So in areas that are developed where access to cholesterol and fatty foods is really high, and also lots of sugar, so we have no problem getting calories in the developed world. In fact, there's too many of them. Basically, low-density lipoproteins are supposed to travel and drop off lipids, and then the protein portion is going to go back to the liver and pick up more lipids. That's ideal. If you've got too many of them, you get a failure of the LDLs to oxidize, and then monocytes and macrophages go ahead and remove it because it's not supposed to be hanging out in the bloodstream. It's supposed to be moving from the blood into the tissues. So the macrophages, as I mentioned, try to deal with that by eating them, and they become foam cells. And then the foam cells elicit an immune response that causes the surrounding of them with connective tissue, and that creates a complicated plaque. There are some predisposing factors that can increase one's risk of developing atherosclerosis. So dyslipidemia, which means improper ratios of lipid types in the blood. So greater than a 3-to-1 ratio of low density to high density lipoproteins. The density portion, again, it refers to the relative amount of fat to protein. So low density lipoproteins have a high ratio of fat to protein. High density lipoproteins have a low ratio of fat to protein. I know that is counterintuitive and sounds weird, but it's true. Amino acids and proteins are denser than fats. That's why they don't mix, among other reasons. So hyperglycemia from diabetes can also cause this. Hypertension can also cause this, and so can the toxins that are introduced into the bloodstream through the lungs from smoking. If the artery affected is an elastic artery, the wall where the plaque is no longer quite as elastic, and so that weakens the spot on the artery and can cause a rupturing aneurysm. In muscular arteries, so arteries that supply muscle, this can basically block off supply, and that leads to ischemic heart disease, which is where your heart's not getting as much oxygen as it should. So both are bad. I think the lesson here is to take care of your vasculature as much as possible. All right, so what you're seeing here is a left ventricle with an extremely hypertrophied wall. So this is a specimen from an autopsy of somebody that had a very hypertrophic left ventricle. So here's the relationship between vessel health and the heart. It seems like it would be really beneficial to have a super buff heart, right? Buff heart equals pumps harder equals moves blood better. You would think that, but what actually happens is a hypertrophied left ventricle reduces the ability of the ventricle to fill because the wall is thick, meaning the lumen gets smaller. So if you can't fill as well, that means less blood gets in and therefore less blood pumps out. So because the hypertrophied wall is working against increases in resistance due to atherosclerosis, it begins to become hypertrophic. And that reduces the ability to fill and impairs heart function. So we call this hypertensive heart disease. So there's that link between your vessels needing to be stretchy and resilient and your heart needing to maintain the same size. Okay, here's a muscular artery. So you can see that there's still elastic fibers, but they're less numerous. But the internal elastic lamina, so these very dark fibers are elastic fibers, and they align the tunica intima of the artery. Small arteries have about 8 smooth muscle cell layers, and then arterioles have only 1 or 2. They still have thicker walls than veins or venules, but not by much. So on the left here, we see a transmission electron micrograph. So these little guys are going to be red blood cells in various views. Oops, sorry, I was itching my chin and I hit the mic. I hope that wasn't too loud for you. And then we have endothelial cell here. And here's a smooth muscle cell. And here's another one. And here's another one. You get the idea, right? So that's showing you a small artery. This is an arteriole. So these are the littlest. These are the ones that you find right before the capillary bed. Capillaries are very, very, very small. So here we see a vein, or venule rather, and an arteriole. What you can see here are the nuclei of smooth muscle cells wrapping around this. And then you have capillaries, which are really, really tiny. So they're smallest diameter blood vessels. They're often smaller than the diameter of an erythrocyte. So that begs the question, how do erythrocytes, how do red blood cells get through? Well, if the diameter of the vessel is big enough, they can go through single file, but also remember that red blood vessels are that discoid shape, so they look kind of like a frisbee almost, with a thin middle. Because of that, they can fold in half like a little tiny taco and squish through the tiniest capillaries in your body. So one of the reasons that your red blood cells are that shape is to perform that tacoing function, so they can squeeze through the capillaries. It's pretty cool. Also fun to imagine little tiny tacos in your blood vessels. Okay, so microvascular pathways. The top one here, the simple pathway, is the commonest. And this is large artery goes to muscular artery, goes to distributing artery, goes to arterioles, and then a capillary bed. And then after the capillary bed, you get increasingly large veins, and it goes right back to the right side of the heart. So this is the most common kind of pathway. It's ubiquitous. These other two are specialized pathways that exist to serve a particular purpose. One is the arteriovenosus shunt. So I mentioned these earlier. Basically, it's a bypass. So you go around the capillary bed, and then arterial blood just goes straight over into venous circulation. This is common in the skin, especially in the fingers and toes, and also the nose, to prevent heat loss. So the more blood surface area you expose to the outside, the more heat you will lose to the outside. So if you've ever gone outside maybe without gloves or something, and you go inside, maybe you go inside to buy a coffee and you have to, for example, sign your receipt, and you find that you have these like frozen claw hands and you can't move your fingers very well. That's because the muscles of your fingers have been denied some oxygen and nutrients, because there's one of these shunts at the base of each of your fingers that shuts when it's really, really cold out. That's also one of the reasons why when frostbite happens, the body parts that tend to be lost are anywhere with an AV shunt. So the AV shunt closes due to the cold, it stays closed, and then if the tissue freezes subsequently, there's no way to repair it because blood can't go to there to initiate inflammation, so you end up losing the digit. A portal system is another very specialized blood vessel system, and these only exist in a couple spots in the body. One of them is the relationship between the hypophysis and the hypothalamus, so your hypothalamus and your pituitary gland. The other is the portal system that involves your liver. We'll talk more about that when we talk about the digestive system. Basically, this is two capillary beds in series. So first one that looks a lot like the simple pathway. So these two resemble each other. So we have oxygen-rich blood entering the capillary bed, and then a portal vein. But instead of going right back to the heart, from the portal vein, the blood enters a second capillary bed. So first and second, before heading back to the right side of the heart. So again, the areas that have these have them for a specialized reason. For the communication between the hypothalamus and the anterior pituitary, it's for communicating with molecules, and for the liver, it's making sure that blood passes through your liver before it goes back up to your heart. We'll talk about why that is when we get to the digestive system and what happens when you mess it up. Alrighty, so we talked about different pathways for capillaries, so different kinds of capillary beds as far as how they're set up structurally. There's also different kinds of tubing. So variation in vascularity is not limited to how the vessels are sort of wired up to each other, but also in what kind of walls do they have. So the first one, A, continuous capillaries, these are the most common kind. So they have tight junctions that seal the spaces between cells. basically they're designed to be limiting leakiness. So they're not supposed to leak very much, and they are allowing for very specific control of what is able to get out or in of the bloodstream. So anything that has to cross has to go by transcytosis. I mentioned transcytosis before, but I want to take a moment to redefine it just in case folks forgot. So this is a passage of materials by endocytosis on one side of a cell, and then a transport vesicle through the cell. Sorry, I ran out of room because my little thing's over here. There we go. Transport vesicle, and then exocytosis on the other side. That's what transcytosis is. It's transit across a cell using a transport vesicle, resulting from endocytosis, and then that's spat out on the other side. B is fenestrated capillaries. So what you're seeing with B is, yes, they still do transcytosis, but they're also leaky. So they have these big fenestrations in them. A fenestration is a hole or a window, and this allows larger things to cross. So why would you want a capillary bed to be leaky? Well, in some places you need more exchange with the blood than normal, or in some places you need to make some kind of a blood filtrate. So capillaries that are fenestrated are found in the endocrine organs, where a gland is making a hormone to dump right into the blood, so the holes provide easy access. The intestinal walls, which help with absorption of nutrients, and the choroid plexus, which is a braid-like network of vasculature in the brain ventricles that produces the cerebrospinal fluid. So there's fenestrated capillaries that are covered over with astrocyte feet and with ependymal cells. Sinusoids are basically capillaries that are not fully complete. So they do have walls, but the walls have large open spaces in them. And they have a discontinuous basement membrane as well. So that's another feature you're seeing here. So in this guy and in this guy, the basement membrane is intact and complete. In the sinusoid, it is not. So just as the endothelial wall cells are full of holes, so too is the basement membrane. So this is found in organs where a large amount of exchange between the blood and tissue is required. So you see these in bone marrow, in the liver, and in the spleen, and that's really about it. They're relatively uncommon elsewhere. Okay, so here we have a capillary bed. You can see an arteriole entering at the left and a venule carrying blood away at the right. And another element that we've added here is a lymphatic capillary. So I mentioned that the lymphatic system is technically a separate system, but it is related. So even if this capillary bed is made of continuous capillaries, which it probably is because most simple pathway capillary beds are continuous as well, plasma still leaks out, and that forms your extracellular fluid. So you have fluid between your cells as well as inside of them. That's important. And the ECF, which is what that is, comes out of your blood. So you get about 85% of that fluid back in the venule side of things, and the rest of it goes into the lymphatic capillary. So that might lead you to ask, well, you said 85% goes into the vein again, and then the rest goes into the capillary, so how do we still have extracellular fluid? Keep in mind that as long as your heart's beating, blood's always going to be flowing through your capillary, which means that you're going to be producing ECF as fast as you're absorbing it, so it'll stay relatively stable. Okay. If somebody has poorly managed diabetes, they're going to have chronically high blood sugar, so hyperglycemia. And this can lead to a variety of maladies of the blood vessels, specifically retinopathy and other angiopathies. So an angiopathy, angio means artery or vasculature, micro refers to the size, and pathy means a disorder of. So microangiopathy related to diabetes is based on the fact that high blood sugar long term initiates some changes in inflammatory processes that cause things like thickening of the capillary basal lamina. So that thickness increases the rate of diffusion, or decreases the rate of diffusion and increases the diffusion distance, and that creates problems as well. So this happens a lot in the kidneys. So folks with unmanaged or poorly managed diabetes often lose their kidney function. You can get diabetic retinopathy, and you can also get it in your skeletal muscle or in your skin. So the skin one is the primary reason why diabetic ulcers form. So ulcers due to ischemia. So medical response here, or application rather, if the endothelial cell junctions, basically places where endothelial cells join, if they clog with leukocytes during inflammation, and they may if enough leukocytes are arriving, basically you get loss of fluid, and that leads to tissue edema. So a localized swelling due to this very function of the clogging of the junctions with capillary or post-capillary causes an increase in the capillary bed pressure, and that causes fluid to leak out. So here's what I mean. Let's imagine, blood is flowing this way, right? And as long as the input equals the output, you get steady pressure. But what would happen if you put a bunch of white blood cells in this post-capillary venule? Then the pressure in the capillary bed would go up, and you'd get more leakage of extracellular fluid out. If you combine that with inflammatory responses involving histamines and heparin, that creates a lot of fluid leaving the capillary and not coming back, which creates localized edema. So that's why you get swelling with inflammation, in addition to this leukocyte clogging phenomenon. Okay, so medium veins. So now we're on the other side of the capillary bed from arteries. We're in vein territory. So we've got thinner walls in the tunica media, so they still have smooth muscle, but they're not as much. And that's because the veins are a low pressure system, so their pressure is functionally 0 millimeters of mercury. You don't have little hearts in your feet pumping blood back up to your heart. So blood flow back to the heart is mostly passive. So that might make you wonder, well, then how does blood get to your heart from your feet if you're standing? Because I know it does, it must. And the answer is your activity of skeletal muscles. So since your veins have valves in them, when you squeeze a vein between two muscles, you're going to squeeze some blood up past a valve. When the blood falls back down due to gravity, the valve shuts, and that prevents backflow. So that's how your skeletal muscle pump works. Not pictured here or mentioned here, but also important, is the thoracic pump. So the simple act of breathing and changing the volume and pressure in your thorax draws blood up your inferior vena cava and azygos veins like a straw. So think about how a straw works. You put a tube in some fluid, and you make the pressure at the top of the tube lower than the pressure inside the tube, ergo fluid moves up. Same exact deal for respiratory pump. When you lower the pressure in your thorax, that means that there's lower pressure in the top of the inferior vena cava, which draws blood up from there. So that's how that works. So low venous return shock is when venous return, so the delivery of blood to the heart by the veins, is poor. So that can come from hemorrhage, it can come from vasodilation, it can come from sepsis. It depends on a variety of things. But regardless of what the cause is, the basic idea is that the heart's not getting enough blood back, which means it can't pump much out either. Excuse me. Venous pooling is when blood does accumulate in the lower body. So standing too long is one thing. I remember my choir teacher in middle school ordering us not to lock our knees when we sang because we would pass out. That passing out phenomenon is real. I know because I experienced it, didn't listen to my teacher. And I did pass out, and that was because of low venous return. I was preventing the blood from returning due to impairment of the skeletal muscle pump. It can also be caused by immune reactions that cause vasodilation and increased vessel permeability, or in old people, just inactivity. So if you're like an older person and you're going to be on a long plane ride, for example, that's why you see old people on planes, excuse me, wearing compression socks to help prevent venous pooling. That's what the point of those ugly socks is. Now you know. Okay, so in the large veins, so these are like your superior and inferior vena cava, there is a thicker layer of smooth muscle. Again, still a low pressure system, but smooth muscle nonetheless. And this allows you to change the diameter of those vessels. There is some evidence to suggest that atrial fibrillation, which is the quivering of the atria, so it's a dysregulation of the electrical signal in the atria. It suggested that intermittent electrical disruption might be somewhat in part due to the smooth muscle cells in the vessels that are nearest the heart, for example. Okay, coronary circulation. So the coronary vessels are those which supply and drain the myocardium itself. So remember how much ATP it takes to contract striated muscle? Cardiac muscle is also striated, so it takes a lot of ATP. What do you need to make ATP? Well, you need oxygen because you have to perform oxidative phosphorylation to efficiently make it. So oxygen and nutrients are something that the heart muscle needs a lot of. So accordingly, its circulation is really robust. This disproportionately increases the blood supply to the heart during exercise, for example. So if your heart rate is up, that means that your heart is working harder to pump and that it requires more fuel and oxygen to do its work. So the left coronary artery is on the left side. So keep in mind patient right and patient left versus your right and your left. So although this looks like the right to us, it's actually the left because you have to mentally turn yourself around. So left coronary artery comes off of the anterior portion of the aorta, and it descends along the front to form the anterior interventricular branch of the left coronary artery, also called the LAD, or left anterior descending. And then the circumflex branch, which goes around to the back. So a skilled emergency medical technician or paramedic can tell using an EKG which coronary vessel is blocked based on the changes to your cardiac rhythm, and you can tell if somebody's left anterior descending branch is blocked. That one's called the widowmaker because that one tends to result in death, unfortunately. So it's not an ideal vessel to have blocked, partially because it supplies a lot of the left ventricular myocardium. The right coronary artery comes off the right side and branches into the right marginal branch, which hugs the margin of the heart, and the posterior interventricular branch, which is on the back here, as you can see. So that's down here. And then we have the coronary sinus, which is this big widened guy here. So this opens into the right atrium. And it drains blood from the posterior interventricular vein, the left marginal vein, and also the great cardiac vein from the front. So the great cardiac vein follows the path of the LAD. So this is how your heart receives blood, and this is also how it's drained. Getting a clot in one of these is called a myocardial infarction, aka a heart attack. The coronary artery is a muscular artery. So these are going to be strong and flexible. The tunica media has lots of smooth muscle, so its diameter can change. The tunica intima is relatively inconspicuous in young people, but it gains fibrous connective tissue and smooth muscle with age. And then we've got atherosclerotic changes as well. So if you were to see that, you would see a complicated plaque in the wall. I believe I have a photomicrograph of one coming up. So you would see this weird aberration in the wall where the three layers, the tunica intima, the tunica media, and the tunica adventitia, had this glob in them. So if that restricts the flow of oxygen and blood to the cardiac muscle, I'm not saying blocks completely, I'm saying impairs it, that can lead to ischemic heart disease, where your heart's trying really hard, but it's not getting very much oxygen or nutrients. And I promised you a plaque. Here it is. So here we can see a muscular artery. And look how much larger in diameter the tunica intima is. That's quite striking, right? Here's the tunica media and the tunica adventitia. So the lumen is tiny here, and then we've got this big complicated plaque full of foam cells and other nasty business. So plaques are not just fat. So there's deposition of lipids both inside of the foam cells, so macrophages, but also outside and around them. You get smooth muscle surrounding that, as well as increased synthesis of connective tissue. So basically the body's immune strategy for having inappropriate LDL deposition is throw some collagen on it and see if that helps. Turns out it doesn't. So as you might imagine, a small lumen like this is going to drastically increase resistance, which is going to make the heart work harder. So if you were to look at this same person's left ventricle, what you would probably see is an enlarged left ventricle. Okay, so I've been talking for a while now, and this video is getting to be the size where it's going to be tricky to upload, plus my throat feels scratchy. So I'm going to stop for now, and I'm going to go ahead and post this. Oopsie. And this should be up for you very shortly. So thank you for your attention, and I will see you in the next video.